Okay, Kat, let's move on to chapter 21, the digestive system. The digestive system consists of what we call the digestive tract, the alimentary canal, and the assorted organs that go along with it. We'll get to some of those later. It regulates the ingestion and digestion of nutrients, and then absorption of those nutrients to be able to transfer around, transfer these nutrients to the body tissues.
No.
So we start with the mouth, go into the esophagus, the stomach, the intestines, and then we have various glands that include salivary, liver, gallbladder, and pancreas that are involved in this process of ingestion, digestion, and absorption of materials. So here is a graphic. The mouth, the oral cavity, we call it, and the pharynx, the salivary glands are on the side of the head. The esophagus leads to the stomach. Okay, the stomach there leads into the jejunum and duodenum, and there's a connection from the gallbladder, which sort of resides up in the cleft of the liver to provide enzymes for dissolution of things like fats. The pancreas allows us to, has a lot of other digestive enzymes that get pushed out and into the gut. The stomach itself has an acid environment that that starts tearing food apart when it gets in there before it's pumped into the small intestine. First, this 30 odd feet or so of tubule that is where most of the absorption of nutrients occurs. And then what's left is moved into the large intestine, which loops around the abdominal cavity and ends at the rectum, which is where we eliminate the solid waste of our digestive process. The oral cavity is sometimes known as the buccal cavity. Cheek, hard and soft palates, tongue, etc. We have the uvula that at the bottom of our throat, that little hangy downy thing that we see, prevents food from getting into the nasopharynx while it's swallowing. The tongue is a skeletal muscle, part of the oral cavity. It's a skeletal muscle that is covered by a membrane. Upper surfaces and sides have these rough patches that contain our taste buds, and we have 5 sensations: sour, sweet, salty, bitter, and what's known as umami, which it translates as deliciousness. Salivary glands are several. They're in the parotid area, they're underneath the lower jaw, and they're under the tongue. They dissolve, the salivary glands help produce secretions that dissolve foods, and the enzyme amylase to start breaking down complex carbohydrates into simpler sugars. The teeth break up the food and are part of the mandible and the maxilla. Temporary teeth form at about 6 months and are usually replaced by permanent teeth by 2 years. The full it takes between 6 months and 2 years. Gradually, we lose those temporary teeth. We call those baby teeth. and there are just a few of those, relatively speaking, 20. The permanent teeth form by the time we get to our teenage years, and we have a total of 32 in a mouth that has all its teeth. There are 8 front teeth known as the incisors, and these are in the front and center of the mouth on both upper and lower, 4 upper and 4 lower. The canines are the pointy teeth that are right next, are the next 4 teeth out, are the next tooth out on each side, top and bottom, for 4 of those. And then the molars are the flat teeth that grind our food. And these can be, these have several different names. The gums cover the part of the bone that actually anchors the teeth. A tooth consists of a crown, a neck, and a root. The root goes into a socket in the bone, and the incisors and the cuspids, or the canines rather. The incisors and the canines have a single root, and the molars have more than one root. The pharynx also is part of the respiratory system. It shared as a shared function, as we know. We talked about that in the respiratory system discussion last week. This is where swallowing begins. We don't swallow what's at the front of our mouth. We have to move it toward the back of our throat and toward the pharynx in order to form this mass or bolus of food that we swallow. Pharynx is where involuntary actions begin. The larynx is pulled forward and up under the tongue to meet the epiglottis, and the epiglottis seals off the glottis, which is what keeps our food out of our lungs. So then this swallowed mass of partially masticated or fully masticated and partially digested food goes into the esophagus and goes to the stomach. The alimentary canal, the walls of the alimentary canal have 4 layers called tunics or coats. The mucosal layer is the internal layer. It's a mucous membrane attached to a thin muscle layer. The submucosa is loose connective tissue. The muscularis is muscle fibers that become folded, that help increase absorption. And then the serosa, the adventitia, the external layer. So we're looking here at the coats here. So we have the mucosa, we have the submucosa layer, and then we have the lumen is the opening, same as in our syringes. We have ducts that come from the glands outside, the exocrine glands. We have a wall for this is the body wall, and we have the mesentery is a series of connective tissues that holds these tubes in place. We have the muscle layer, okay, and we have the outer layer known as the serosa. Okay, so mucosa, submucosa, muscle, and then the outer layer, the serosa. Okay, and so we have these structures in here. We won't go into those. The muscle lining the mouth, the tunica muscularis lines the mouth, the pharynx, and upper esophagus. It's skeletal muscle. The remainder of the inner canal, the alimentary canal, has an inner circular layer and outer longitudinal layer of smooth muscle. The serosa is a membrane with connective and epithelial tissue, also known as the visceral peritoneum, and covers the organs. It's a cushion and protective layer. An extension of this layer is the mesentery, a double layer that suspends the various parts of the um, of the um, of the small bowel, the intestines, and keeps them um, capable of free flow of material through it. The esophagus is a tube. We talked about that. It starts at the laryngopharynx and passes through the mediastinum. It enters the diaphragm through what we call the esophageal hiatus. This is the opening that gets ruptured in a hiatal hernia. Okay, so it secretes mucus and moves food to the stomach via peristalsis. The stomach is a body cavity. It's under the diaphragm, and it stretches. It's variable in shape. It has four parts. Um, the gastroesophageal sphincter, right at the base of the esophagus and the top of the stomach. The sphincter there is what leaks when we have GERD. The fundus is a rounded area, and then there is a large central portion, which is the body, and then to go to the duodenum. The duodenum is this narrow area that connects via the pyloric sphincter. It's called the pylorus. So when it's empty, it has large folds, or what we call rugae, in the mucosa. It really is sort of like everything just sort of folds up to have the stomach, when it's empty, not fill up space and be full of nothing, air. So these folds then smooth out and as it fills with food. And there we have gastric glands in the mucosa, and they have a number of different secreting cells. Um, the chief cells generate pepsinogen, which is a precursor enzyme that causes that that breaks down into pepsin, which is one of the digestive enzymes. The parietal cells secrete hydrochloric acid. That's why the stomach is acid. And then we have mucus cells, which secrete mucus, which is what protects the lining of the stomach from this nasty acid. Pepsinogen is the main gastric enzyme. Hydrochloric acid activates pepsinogen to form pepsin, which then starts breaking up protein. Parietal cells also produce a factor that will allow for the absorption of vitamin B12, which is a really nasty, well, not nasty, it's a giant molecule. And then, of course, the mucus protects it. Secretions of the stomach form what we call gastric juice. The stomach has an outer longitudinal layer, a middle circular layer, and an inner muscular layer that contract. This is the stomach, moving to mix the food. It's just like pulsing to mix the food. And then in the stomach, we begin to use the hydrochloric acid and pepsin to digest proteins. Within 2 to 6 hours after eating, the contents of the stomach will move to the duodenum, and then carbohydrates will go first, then proteins, then the fatty foods. It also absorbs some water and salts, and drugs like aspirin and alcohol are absorbed in the stomach. The small intestine is the largest portion at 21 feet. The shortest part, the duodenum, begins at the pyloric sphincter and is 10 inches long about. Then the next 8 feet are the jejunum. And then finally, we've got about 12 feet of ileum, which is, it joins it connects the jejunum to the large intestine via what we call the ileocecal sphincter. In the small intestine, there's an alkaline mucal secretion by the duodenal glands in the duodenum. A series of cells known as goblet cells secrete a lot of mucus, protecting it from being digested itself. Mucus neutralizes the acids in chyme, the digested contents of the stomach, which is now semi-fluid and a bit on the viscous side. The small intestine absorbs about 80% of the nutrients, including all these things, the amino acids, the simple sugars, fatty acids, water, vitamins, minerals. The mucosal coat has villi, little projections that basically look like little fingers that stick out into the intestine. And what they do is increase the surface area for absorption. So then there's a border of these little bitty villi, microvilli, that coat the surface of each of the villi to increase absorption further. So here we have a bit of a diagram. We have the esophagus coming down from the throat, from the pharynx, entering this area, the fundus, this rounded portion that actually rises above the entrance of the esophagus. The body of the stomach follows. Here we have the pylorus area and the pyloric sphincter, also known as the pyloric valve, moving into the duodenum. Okay. And then into this twisty, windy stuff called the jejunum. And then the next 12 feet or so are the ileum, moving into the ascending large colon, ascending colon, the base of which is called the cecum. This is where the appendix comes off. So this is the right side of the body. The large intestine then loops back over the small intestine. So we have an ascending, a transverse, and a descending loop. So absorption here in the stomach, if we can, let me see if I can make this a little bigger. Here we go. Okay, so we have this layer. We have these little structures, the plicae, and these are the villi. The plicae is where the villi are located. So we have the villi and then the microvilli that come off them. So we have a tremendous surface area for absorption of our nutrients. Then if we have a little micro view of a microvilli, okay, this is what we're looking at. This is a section of the microvilli, or the villi and microvilli. So we have the lacteal glands and these goblet cells here. And then we have since all these things are absorbed into the circulation, we have the arterioles and the venules that accompany that. The large intestine is also known as the bowel, where we absorb water and actually get involved in manufacturing vitamins, and it forms and expels feces. It's about 5 feet long, but wide. It's shorter. So it's shorter, but it's quite a bit wider at nearly 2.5 inches. And it is attached to the posterior wall of the abdomen by part of the mesentery, the mesocolon. The cecum is a 3-inch section that joins the small valve via the ileocecal valve. The colon is the longest section. It has pouches dividing, and we call those haustra. And it's divided into ascending, transverse, descending, and at the very end, the sigmoid portions. And then after the sigmoid, we go to the rectum, which is about an 8-inch long section near the sacrum and the last bone of the spinal column, the coccyx. The anal canal is about an inch long, and it is highly vascular, and it opens to the exterior via the anus itself. So there is an internal and an external sphincter that the anal canal is controlled. These are involved in making certain that we can maintain continence. Difficulties there will cause incontinence. So bacteria in the large intestine manufacture some very important molecules, vitamin K, which is critical in clotting, as you know, biotin, and vitamin B5. Feces is formed after the chyme has remained in the large intestine for 3 to 10 hours. It consists of water and epithelial cells, salts, bacteria, and undigested food. So here's again a picture of the large intestine. So again, the ileum, the small bowel, connects here in the cecum area, which is about a 3-inch wide area here through this valve, the ileocecal valve. And here is where the appendix comes off. The appendix has actually been found to be important in our immune system. So it apparently is a good storehouse for intestinal bacteria when we need to repopulate as well. So it's followed by the ascending colon. The hepatic flexure basically says this is it when it hits the liver, it bends. And it bends to the left, goes across the transverse colon to again over by the spleen. It bends again. The spleen is the splenic flexure, and then the descending colon till we get to the point where there's another rise, the sigmoid colon, going into the rectum. So this is the internal anal sphincter, which is a smooth muscle layer here that closes it off, and this is the anus itself and the external anal sphincter. So this is how we control how much or how fast feces comes out. The accessory organs of the digestive system are the pancreas, which is beneath the stomach, and it's has a multi-function process. It's part of the endocrine system as well. It's part of the digestive system. It has so it does a lot of these things. It secretes glucagon and insulin, and a number of important digestive enzymes come from the pancreas. The liver is the largest gland in the body. It has 3 lobes, 500 functions. The liver is one of the few organs that will regenerate. So if you have the if you were to donate a liver to a liver transplant patient, what they would do is basically take a section of your liver, a lobe maybe, and put it into the patient, and assuming the patient accepts that liver, their liver will grow, and yours will grow back. The gallbladder is a little, it says a pear-shaped organ, but it's not pear-sized. It's quite small. In fact, it's only a couple of inches long at most. And it sits next to the liver, connects to the digestive tract, and it too puts out bile and a number of other bilirubin and a number of other um, digestive materials. So here we have the pancreas. It's about 6 inches long, and it is sort of has a head, and then it tapers off through the body to a tail. It contains we talked about the islets of Langerhans that secrete insulin and glucagon from the two types of cells, the betas and the alphas. Um, it also releases pancreatic enzyme mixtures, lipases. These dissolve fats, carbohydrates, which help metabolize carbohydrates, and proteases, which help metabolize protein through the pancreatic duct. And then the liver itself produces bile and plasma proteins. It metabolizes drugs. It removes damaged cells, blood cells. Um, you can store and secrete glucose, vitamins, minerals, fats, amino acids. It's a chemical factory of the body. It's the main toxin clearing organ. There are two main lobes separated by a ligament, and it weighs about 4 pounds in most people. Gallbladder stores bile that's produced by the liver, concentrates it from liver lobules, and releases it into the small intestine to help through the common bile duct, and releases it into the duodenum. Disorders, there are many disorders of the digestive system. GERD, gastroesophageal reflux disease, and a related disease known as Barrett's esophagus, or a related condition. Ulcers, Crohn's disease, ulcerative colitis, these are inflammations of the intestine. Diverticulitis, inflammation of the diverticula in the intestine. Pancreatitis, cholelithiasis, these are gallstones. Cholecystitis, which is an inflammation of the gallbladder. Hepatitis of varying forms. The most common that we know of are viral, but other non-viral infectious organisms can cause hepatitis. The term hepatitis is merely a descriptor. It's an inflamed liver, and there are many things that can do that. And of course, we can have liver cancer. GERD occurs when we get stomach contents backflowing into the esophagus, past that sphincter at the end of the esophagus and at the top of the stomach, without vomiting. So the symptoms are heartburn, uh, belching, coughing, all sorts of other things. The acid can start eating away at the esophagus, which is why we want to treat it, and ultimately cause a hernia in the esophagus. And the acid can also come up and erode tooth enamel. Treatments, well, there's some physical things you can do. Elevate the head of your bed by about 6 inches so that when you lie down, stuff isn't splashing out of the stomach. Gravity is keeping things in the fundus. Eating several hours before going to bedtime, taking certain drugs, antacids, H2 receptor antagonists like Tagamet and Zantac, proton pump inhibitors, and others. Losing weight's a good idea if you happen to have GERD. Don't use alcohol or smoke. And for severe cases, there are some surgeries. Barrett's esophagus is a replacement of the usual cells with abnormal epithelium, and this often results from chronic GERD. It is a risk factor for adenocarcinoma, a cancer, and the symptoms are exactly the same as GERD. Treatments, we can take medications, we can change lifestyle, there can be surgical and regular exams to see what's going on with the area at the base of the esophagus. Peptic ulcers are lesions in the mucosal membrane of the esophagus, stomach, and duodenum, and they can be acute or chronic. They may be caused by a bacterium called Helicobacter pylori, and about 80% of these peptic ulcers are actually in the duodenum, and usually in men who are 20 to 50. Gastric or stomach ulcers are more common in middle-aged and elderly men. Peptic ulcers, the symptoms in the stomach, we have heartburn, we have epi or above the stomach pain, we get uncomfortable fullness after eating. In the duodenum, we have lower, what we call mid-epigastric pain, lower down. Heartburn, the symptoms of heartburn, sometimes severe upper abdominal pain and nausea and vomiting. Complications can be hemorrhage with associated shock, perforation of the gastric wall, which exposes the contents to the abdominal cavity, and the contents are not supposed to be there. That can have some pretty unpleasant results as well. Infections and pain and other types of symptoms. Each section is separated by, they have a constricted area. Sometimes there are sphincters and sometimes not, but in some cases there can be an obstruction at one of those outlets. Treatments: stress reduction, change diets, restrictions on restrict alcohol, and don't smoke. Get more physical activity. There can be histamine receptor blocking, the H2 antagonists, antacids, the Tums, etc. Some things that can be used to coat the mucosal lining to protect it. We have proton pump inhibitors, the Nexium, etc. Antibiotics, if we know that Helicobacter pylori is involved. We can even do surgery, and for severe cases where we have hemorrhaging and so forth, we may have to give transfusions. Crohn's disease is an inflammation of the small bowel, and it can be accompanied by ulceration as well, holes in it. It's also known by these other names: regional enteritis, granulomatous or granulomatous colitis, ileitis, and ileocolitis. They're all are the same thing, and they tell you that the fact that we got itis in the disease tells us that it's an inflammatory disease. Most common in people between 20 and 40, and I believe it's more common in men than women. Causes can be infectious agents again. It can be immunologic. You can have some immune system dysfunction that's causing the problem. Diet, psychosomatic illnesses, allergies, genetics appears to run into family, and then some factors that are consistent with autoimmune disease. fever, diarrhea, abdominal cramps, fullness, weight loss, nausea, anorexia, abnormal appetite, all sorts of problems can result, including abscesses in the colon or in the ileum. Treatments, we can use certain forms of dietary supplements, immunosuppressants. The pain is treated often with narcotics. Um, if we know that there's a bacterial involvement, we can use antibacterials. Steroids are used, um, and and IV nutrition in order to keep food out of the area and causing further inflammation. Ulcerative colitis is another inflammatory disease, but this one usually um, you can see from colitis that it is of the colon, and it affects the mucosa of the colon. It causing edema, swelling, and some ulcerations, some wounds in the side. If it's severe enough, it can even perforate the colon, spilling some of those bacteria that are in there into the abdominal cavity, which uh, can potentially lead to peritonitis, toxemia, and even be fatal. It's most common in young adults, um, and what we see is um, they will see a cycle of the disease getting worse, getting exacerbated, and then getting better or going into remission. Um, and it also can occur in older symptoms. These are pretty nasty symptoms: bloody diarrhea, cramps, urgency, mucus in the stool, frequent and very loose stools, weight loss, etc. Treatments, so far we've used um, we've tried to get people to have low fat diets and low in bulk. We use certain anticholinergic drugs. Sulfasalazine is often used. Corticosteroids. We try to use antidiarrheals. Um, there are times if the disease is pretty local or pretty focal, we can simply resect part of the colon, and and then keep an eye out on the patient. Diverticulitis is inflammation of the diverticulum, which is um, again little fingers that stick out um, uh, into the bowel, and it's an inflammation that's usually um, due to entrapment of feces inside the bowel. It may um, cause um, an obstruction in the bowel, in which case surgery is often needed. Um, but something else um, is diverticulosis is a milder and more common form here that just is a defective poking out of these things in the muscular walls. The is usually caused um, by inadequate fluids, lack of bulk in the diet, and constipation. The symptoms include fever, abdominal pain in the left lower quadrant, as opposed to abdominal pain in the right lower quadrant, which we associate with appendicitis. Um, Distension of the abdominal area, nausea, changes in bowel function, feeling an abdominal mass, and blood in the stool. Um, Perforation, abscesses, and fistulas, which are um, um, basically bubbles, are complications that may occur. Treatments, well, we try to prevent the constipation. We look for infections and try to treat those. If there's hemorrhaging, we look for medications to try and do that, um, to cure that. We look at stool softeners and liquid diet. As I said, surgery can be done as well. Pancreatitis is an inflammation of the pancreas, and it can be acute or chronic. The pancreas is so involved in so many parts of the body through insulin and glucagon that the inflammation of the pancreas can affect other organs. That's what pancreatitis is. There's an acute form that can be linked to a number of different potential causes, including alcoholism, biliary tract disease, infection, trauma, in other words, just an injury, high calcium levels in the blood, drugs, etc. There are several things that can be there. The acute symptoms are abdominal pain radiating to the back, nausea, vomiting, pain when walking or lying, sweating, fast heartbeat, rapid and shallow breathing, fever, and low blood pressure. These are the acute symptoms. Chronic symptoms, constant back pain, anorexia, nausea, vomiting, constipation, flatulence, and weight loss. Treatments, well, IV fluids and electrolytes, no food by mouth. Um, we can use a nasogastric tube. Um, the To make sure that the stomach is kept clear. We can give analgesics and a certain other um, drugs, and we monitor for diabetes. Pancreas, since the pancreas is responsible for generation of insulin, we worry about diabetes when it's sick, um, and the uh, so we watch very closely for that. Um, if there are abscesses in the pancreas, we may need to drain those abscesses to cure it. Cholelithiasis is gallstones, which is in the bile, formed from insoluble cholesterol and bile salt mixtures, most common in older women and obese people. Um, Risk factors include a high-fat diet, pancreatitis, diseases of the ileum, contraceptives, oral contraceptives, alcohol, cirrhosis, etc., and diabetes mellitus. Biliary colic, which is with pain radiating to the upper back, nausea, vomiting, clay-colored stools, jaundice. We can be jaundiced with cholelithiasis. Again, we can look at several things. Surgical removal of the gallbladder is common, cholecystectomy. We can use um, uh, agents to dissolve the gallstones if we can get them done, and we can use the lithotripsy the same as with kidney stones. We can use lithotripsy, the sound waves to physically break them up. Cholecystitis is an inflammation of the gallbladder. It can be acute or chronic. Can be caused by an obstruction of the duct, by the duct from the gallbladder by the gallstone, um, or trauma or other damage. Pain in the upper right abdomen intensifies as it radiates. Um, so there are several things. Shallow respirations, because pushing on it by breathing is not comfortable. Cholecystitis is an acutely inflamed gallbladder that may rupture. If that happens, we risk peritonitis, which is a potentially fatal condition. To control it, we can eliminate fatty foods. We can use tube feeding or IV, and other drugs as necessary, including painkillers and surgical removal of the gallbladder. Non-viral hepatitis is usually something that happens um, from drugs and or certain chemicals in the environment. Um, the the chemicals can include carbon tetrachloride. That's why we no longer allow that to be used in dry cleaning. Some of the nastier mushrooms, and vinyl chloride, which is a common chemical used in the organic chemistry industry, the chemical industry. Drugs that have been linked to a non-viral, virally caused hepatitis include niacin, halothane, which is one of the inhaled um, anesthetic gases, sulfonamides, isoniazid, Tylenol, acetaminophen, methyl dopa, which is used often for treating, can be used for treating Parkinson's, and the phenothiazines, and of course, alcohol. Um, Usually, non-viral hepatitis is associated um, as something that appears after someone has been through fatty liver disease, and it may precede cirrhosis or liver cancer, and it can lead to liver failure. Most patients can recover if we can catch it and figure out what's going on, and help them get over the disease, the condition. But there is a fulminant form, which means just sudden and very severe, which often is very, very dangerous to the patients. Um, Causative agents have to be gotten out of here, and have to be gotten out of the body somehow. Viral hepatitis, we know these. There are 6 different forms of viral hepatitis. This is an infection and inflammation of the liver, and it ends up in hepatic cell destruction. It's the 10th leading cause of death for adults in the USA. And there are 6 hepatitis viruses: A, B, C, D, E, and G. Hep A is fecal oral. It's foodborne, or it can be foodborne. It is There's a vaccine that is available, that can be that now is being recommended for all American children between 12 and 23 months of age. Hep B is bloodborne, as you remember from um, your Med 102 class. Can be transmitted a lot of ways: contaminated plasma, sharps, contaminated sharps, um, sexual contact, or splashing of contaminated material into sensitive tissues, eyes, nose, mouth, or broken skin. Can also be transmitted from infected mothers to their infants. Um, can result in a prolonged illness and become chronic, and cause cirrhosis, um, also known as serum hepatitis. The virus can survive for a week or more on surfaces in the environment. 90% of the patients will recover after an acute phase. The immune system will step in and start taking care of it. but the remaining 10% can develop chronic disease. The vaccine is very effective. It is available in a variety of different forms. It can be combined with others, including the Hep A vaccine. Most of the time when we talk about a hepatitis B vaccine, we're talking about something that is a vaccine that is what we call univalent. It only targets one potential disease, whereas these others that can include um, can include HB virus vaccine. We can have that with these other vaccines as well. Hep C was known as non-A, non-B. It's a chronic form. Again, it's bloodborne. You can have the same thing as Hep B. There are drugs to treat it, but there is no vaccine, and we don't have, all we can do is treat the infection and hold it at bay. Hep D is known as Delta disease, was known as Delta disease. It only occurs with Hep B infection. So in reality, even though there's no specific Hep D vaccine, since it can only occur conjunctively with Hep B, the Hep B vaccine can prevent it. It too is a bloodborne disease, not common here in the US. Hep E is another acute disease. It's more common in Africa, South America, and Southeast Asia, and southern India. It's similar to Hep A in that it is transmitted by the fecal oral route. We don't really have a test to it. Apparently, pregnant women are most at risk of dying of that disease. Hep G is caused by what we call a flavivirus. It's usually spread by contact with blood, maybe semen. We have no vaccine. Viremia, in other words, we can be shedding virus for months or years with this one. I'm not very familiar with Hep G, so I don't have much to say about it. Symptoms vary between the types of hepatitis, but headache, anorexia, dark urine, nausea, clay-colored stools, jaundice, nerve pain, liver enlargement, and abdominal discomfort are common. The treatments are to restrict activity and rest for most of these. We can give intramuscular immune globulins to patients. We can make sure that the pain is reduced. We advise staying away from alcohol. It's a liver toxin anyway, and your liver's already in stress. And look for low-fat, high-carb diets. We have some drugs for hepatitis B and C. Quite a few drugs. This only lists a couple, but there are a number of drugs that have been approved in recent years, especially for Hep C. The Hep B vaccine has really lessened the need for drugs for treatment. Liver cancer is also known as hepatocellular carcinoma, is often linked to hepatitis B infection, but it can also come from cirrhosis, which we know can come from substance abuse and from exposure to environmental toxins. The a disease known as hereditary hemochromatosis, or the aflatoxins from molds rather can cause liver cancers. Secondary liver cancer is the most common form of this, and it comes because the cancers in colon, lung, breast, and prostate can metastasize to the liver. Abdominal pain, early fullness after eating, jaundice, enlarged liver, ascites, which is a buildup of fluid in the abdominal cavity, and enlarged spleen. Treatments, if it's localized to one part of the liver, we can take that out. We can use some other forms, and extreme cases, we can do liver transplantation. We can try to kill the cancers by directly injecting ethanol into the affected tissues. I would imagine that's not very fun. We can also use radio frequency um, um, radiation to destroy the cells. Um, the drugs we can use for these kinds of disorders include this list here, plus many others, antacids. We'll also be using painkillers. For the viral liver diseases, we have a number of drugs for treating that now, antiviral drugs. Histamine receptor antagonists, proton pump inhibitors. These can be used for treating, largely used for treating ulcers. Antidiarrheal agents to help reduce the symptoms of the various forms of colitis, Crohn's disease, and ulcerative colitis. Um, Laxatives for constipation, and stool softeners for as well. So there's lots of these things. So I'm going to minimize and I'm going to stop here. On Wednesday, we'll pick up with the last chapter, chapter 22 here. And let's go back to modules. So what you need to be working on this week, I want you to note that there is no assignment this week. You do have a final assessment. Let's just make sure, yep, you can do this 3 times so you have a chance to maximize your grade on that. But also remember there's this career integration little 3 essay exercise you have. And I'll figure out what kind of in-class activity we will do on Wednesday as well. So then you have your discussion, which we know is about conditions, treating conditions of the lymphatic system. Okay, so I will see you on Wednesday.